Hello and welcome, everyone. We'll begin in just a minute as people are still coming in. Hello and welcome. We'll begin in just a minute as people are still coming in. Hello, everyone. We'll be beginning in just a moment. Hello and welcome to our Impact Program webinar. Today's presentation is Gastric and Pancreatic Cancer, What You Should Know. I am today's moderator, Jillian Sotelo. During the presentation, we encourage you to use the chat box to engage with other attendees and panelists. Anything written in the chat box will have your name associated with it. All questions should be asked in the Q&A box on the top bar of your screen, which may be submitted anonymously or with your name attached. Questions will be answered at the end of the presentation. As a reminder, we are recording this event to be made available in the next few days on the Impact Program Cancer Care CSC site. Julie Goldstein, one of our Impact Program navigators, will be discussing today's topic with additional information about our Impact Program leader, Kelly Nickelbeim. Julie, thank you for joining us today.
Hi, everybody. Jillian, thank you so much for that kind intro. We have a lot of information to cover, so let's just jump right in. The very first thing I want to mention for all of you to keep in mind as we go through the information today is gastric and stomach are the same thing. So if you hear me say gastric cancer or stomach cancer, I'm referring to the same disease. I will try my hardest to be consistent and just say gastric cancer, but I can't promise anything. So this is just a look at what we're going to go through today. We'll talk about gastric and pancreatic cancer, the symptoms of those diseases, risk factors, screening, ways to even reduce your risks of those cancers. Then we'll spend a good chunk of time at the end talking about how gastric and pancreatic cancer can sometimes run through families and how genetic testing might be helpful to determine if a family has an inherited higher risk. So just to give you a visual, this is where the stomach and the pancreas are in the body. They're both on the left side in the abdomen or the upper belly. You can see the stomach is there right under the ribs, and the pancreas is that little yellow piece sort of peeking out from behind the stomach. So it's buried pretty deep in the abdomen. So we'll first start talking about the stomach and what gastric cancer is. So basically, we all know, again, that the stomach is an organ that's located in the upper left part of our abdomen, just under the ribs, and its job is to help with digestion. So when we eat food, it gets stored in the stomach, and then the stomach helps to break it down and send that food slowly into the small intestine so that our body can absorb the nutrients from the food. Just like any other type of cancer, gastric cancer is when normal cells start developing uncontrollably or inappropriately. So gastric cells divide and grow, but if they divide and grow with no mechanism to control them, they can develop into a tumor or a mass referred to as gastric cancer. Gastric cancer typically starts in the lining of the stomach, and then it can grow further in or deeper into the stomach wall over time. There are several different types of gastric cancer. We could probably spend this whole webinar talking about just the different types of gastric cancer. But today we're going to focus mainly on the adenocarcinoma type of gastric cancer. This is the most common type. So 90 to 95% of gastric cancers are going to be adenocarcinomas. Just to make it even more complicated, those adenocarcinomas can be divided into subtypes, an intestinal type, as well as diffuse type. That'll come into play a little bit more when we talk about the inherited gastric cancer syndromes, so just something to tuck away for now. We can also see gastrointestinal stromal tumors, which are tumors that develop in kind of specialized support cells around the stomach. We can see neuroendocrine tumors of the stomach, which start in the cells in the stomach that act like nerve cells in some way and kind of like hormone making cells in other ways. These tend to grow more slowly than the adenocarcinomas. Lastly, they're very rare, but we can actually see lymphomas in the stomach. These are cancers that start in the immune cells in the walls of the stomach. Again, very rare. So let's just focus on the adenocarcinomas for today. That's something to keep in mind here when we're talking about the symptoms of gastric cancer. So when we talk about the symptoms of gastric cancer, I am talking about those most common types, the adenocarcinomas. It's important to remember that unfortunately, a lot of the early symptoms of gastric cancer are pretty vague, or people might not even have symptoms at all until the gastric cancer advances. And a lot of these symptoms that you can see on this slide, such as bloating, indigestion, heartburn, fatigue, these are all things that we probably all experience from time to time. What's concerning is if these are persistent, meaning they're lasting more than a couple weeks at a time, they're not getting better, nothing's making it go away. And as stomach cancer advances, we can see some more concerning symptoms like unexplained weight loss, meaning you're just losing weight without trying at all. You're developing jaundice, which is a yellowing of the skin. You might even see blood in your stools or black tarry stools, nausea, vomiting, again, happening on a persistent level, not just coming and going. There are many different factors that can impact a person's development of gastric cancer. I always like to point out that for most people, there's not one single risk factor that caused their gastric cancer. It's more likely that most people have sort of a profile of these different risk factors that could work together to give somebody gastric cancer. And you can see too from this chart, there are some factors that we can change and some that we can't. For example, we can't change the fact that males are more likely to develop gastric cancer. It tends to develop in people over the age of 50, although many of us have been trying to find the fountain of youth, still haven't found it yet, so we can't alter that. Having a history of pernicious anemia is actually one of the strongest risk factors for gastric cancer. This is an autoimmune condition where basically cells attack the lining of the stomach. It does result in low B12 levels in the body, but it also does do harm to the lining of the stomach that can lead to changes associated with gastric cancer. Having a family history of gastric cancer or other gastrointestinal cancers can increase your risk, as well as having a history of inflammatory bowel disease. Always want to be very clear to point this out. This is things like Crohn's or colitis. People sometimes get confused when they see IBS, which is irritable bowel syndrome, not the same thing as IBD, which is an inflammatory bowel disease. Having a history of a previous stomach surgery can also increase your risk for gastric cancer. Then there are some factors, fortunately, that are modifiable. Having a bacterial infection called H. pylori, which I'll talk a little bit more on the next slide, use of alcohol and tobacco, which can be modified with lifestyle changes. A diet rich in salt and nitrates and low in fiber can increase gastric cancer risk, again, a modifiable factor, along with high BMI. So I said, fortunately, some of these factors can be modified. First is identifying and treating H. pylori. This is something to speak with your physician about if you have concerns, but there is a very easy test to see if somebody is infected with H. pylori. Again, a bacteria that affects the lining of the stomach, and it just takes a simple course of an antibiotic to treat H. pylori. Typically, you treat it once and it's gone, and that risk of gastric cancer is eliminated. Also, lifestyle factors such as eating healthy, quitting smoking, drinking in moderation can all help to modify your gastric cancer risk. With eating, the goals would be definitely getting fiber, eating fruits, vegetables, and whole grains that are going to contain vitamins and minerals and antioxidants that we know can play a role in cancer prevention. We talk a lot about smoking cessation in relation actually to most cancers, so gastric cancer isn't alone in that. We know that smoking cessation decreases the risk for many different types of cancers, as well as even other non-cancer chronic health conditions. So talking with your physician about what might be the best way for you to quit smoking is a really important thing you can do to lower your gastric cancer risk. As well as drinking in moderation. So, it isn't recommended that you have to completely cut out alcohol, but if you do want to modify gastric cancer as well as other cancer risk, choose to drink in moderation, which means limiting alcohol to about 1 drink a day for women and 2 for men. And those are average drink sizes. So, not a 24-ounce pour of beer. And you can look on the Center for Disease Control's website for more information about what 1 drink is considered. Again, maintaining a healthy weight also can reduce risk. So now that we've talked a little bit about the symptoms and the risk factors for gastric cancer, you might be wondering at this point, well, how do I know if I have it? Should I be doing screening? Is there anything that can be done to assess whether or not I have gastric cancer? So in the United States, there is really no routine screening for gastric cancer for people at average risk. So what I mean by that is in the United States, you know that everybody over the age of 40 is recommended to have a mammogram, or everybody around age 45 should start colon cancer screening with colonoscopy. It's a little bit different with gastric cancer. We don't have specific recommendations, and there are a couple reasons for that. One, in the United States, gastric cancer is actually pretty rare. It's not very common. So there really hasn't been a screening regimen that's been shown to provide an overall benefit, meaning identifying enough cases of gastric cancer to balance out the risks of doing the procedure. The way gastric cancer screening is done is through something called an upper endoscopy. Some of you might have had one before. So this is a test where a physician, typically a gastroenterologist, inserts a thin tube into your stomach, or I'm sorry, into your mouth, and it goes down through your esophagus, into your stomach, and into the first part of your small intestine. And it has a little camera on the end of it where they're able to look directly at the stomach lining. So again, it's an effective tool in screening for stomach cancer, but it has risks in the sense that it's invasive and that it requires sedation. Now, if somebody does have symptoms of gastric cancer or significant risk factors, then their physician might recommend doing screening with upper endoscopy. The frequency and age to start would really depend on what those risk factors are. Okay, we are going to switch gears, talk about pancreatic cancer, and then at the end we'll pull it all together. So I already showed you on the first diagram where the pancreas is, kind of tucked behind the stomach and the abdomen. It's pretty small, it's about 6 inches long, and it looks almost like a flat pear in the body. The pancreas has a couple different jobs. First, it helps with digestion. So there are exocrine cells in the pancreas, and those make the digestive enzymes that get released into the pancreatic ducts that help our small intestine digest our food. That might be way more of an anatomy lesson that you wanted, but just remember part of the pancreas job is to help with digestion. The pancreas also has endocrine cells, which make hormones like insulin, and releases those into the bloodstream to do things like control blood sugar. So there's a couple different parts to the pancreas and how it behaves. Again, when we were talking about gastric cancer, same thing with pancreatic cancer. There are multiple different types of pancreatic cancer. Just like with the gastric cancer, we're going to focus on the adenocarcinomas today. About 95% of pancreatic cancers are going to be those exocrine cancers, which are adenocarcinomas. They usually start in the duct of the pancreas. Again, by far the most common type of pancreatic cancers. Those endocrine or hormone producing cells of the pancreas can also develop into cancer. Those are called pancreatic neuroendocrine tumors, or sometimes islet cell tumors. Much less common, but they tend to have a better prognosis. When we talk about the symptoms of pancreatic cancer, really a reiteration of what I said about gastric cancer, in the sense that unfortunately there aren't very many early signs of pancreatic cancer. Some of these symptoms can be things that you would experience from time to time on your own. Some of these things, as the pancreatic cancer gets more advanced, you might see. Some very particular things to pancreatic cancer that you might not see with other conditions would be a sudden onset of type 2 diabetes. So somebody who just out of the blue develops diabetes when they haven't necessarily had the risk factors before to show that they were at high risk for diabetes, that can be an indication that the pancreas isn't working properly. We can also see an enlarged gallbladder or liver, which can be an indication that something's not working right with the pancreas. Some of the more vague signs can be abdominal or back pain, jaundice, again, which is the yellowing of the skin or the eyes, nausea, vomiting, fatigue. Very important to remember that all of these symptoms can be seen in other more benign causes. But if you're having persistent symptoms like this that aren't going away, definitely worth a conversation with your physician. Okay. Pancreatic cancer also has risk factors that can be modified versus ones that we can't change. So, one of the risk factors for pancreatic cancer is also being male. We know males have a higher risk of developing pancreatic cancer. Pancreatic cancers tend to develop in people older than the age of 50. Having a history of diabetes, mostly type 2, does increase the risk of pancreatic cancer. Having a personal history of chronic pancreatitis. Pancreatitis is inflammation of the pancreas. That can be hereditary or non-hereditary, but having a history of that increases pancreatic cancer risk, as well as having a family history of pancreatic cancers and some other cancers, which we'll review later when we discuss those hereditary syndromes. We do know too that there are other risk factors for pancreatic cancer, again, that are modifiable, such as workplace exposures, use of tobacco, and an increased BMI. Limiting workspace chemical exposure is something that you can do on your own to reduce pancreatic cancer risk. So we know that the main players here would be benzenes, chlorinated hydrocarbons, pesticides, and asbestos. The best way to limit exposure is to follow safety precautions at work, using things like masking, gloving, working under a hood, using proper ventilation, following all of the OSHA guidelines that are established to help limit workplace exposure. I won't talk too much about all of the other ones since we talked about it. First, gastric cancer, basically the same thing. Quitting smoking, drinking in moderation, and maintaining a healthy weight can decrease pancreatic cancer risk. Okay. Now we're going to focus, just like we did with the gastric cancer, and pancreatic cancer screening. Same idea that there are no major professional groups in the United States that recommend routine screening for pancreatic cancer for people who are at average risk. So just like with the gastric cancer, the screening has not been shown to kind of be worth it as far as a cost benefit analysis with the risks of having the procedures performed. Pancreatic cancer screening is really reserved for people who have certain risk factors, including family history, again, the age at which to start, the screening frequency, the screening methods really depends on that person's personal and family history factors. So that's a discussion for somebody to have with a physician, their own physician, if they are having, if they have concerns about pancreatic cancer risk. Pancreatic cancer screening is actually even more specialized than the gastric cancer screening we discussed, typically done at specialized centers, and not even every gastroenterologist is trained to perform these procedures. So it's a much more specialized situation that requires more advanced training. Pancreatic cancer screening, though, is typically done with a combination of two different screening regimens. First is an endoscopic ultrasound, very similar to what we talked about before with the tube that's passed down through the mouth into the stomach and small intestine. This time, though, instead of a camera being on the end of that tube, an endoscopic ultrasound, there's actually an ultrasound device. So within the body, the physician is able to do an ultrasound and get detailed images of the pancreas. Just like the upper endoscopy we talked about earlier, this is also done under sedation. MRCP, I'm going to attempt to pronounce this, magnetic resonance cholangiopancreatography. How did I do? MRCP is a special type of MRI scan that for all practical purposes for the patient feels like a regular MRI, but the MRI is taking a look at the pancreas and the pancreatic ducts. Again, not done everywhere, usually done at more specialized centers. Now we get into the good stuff. The genetics or hereditary predisposition to gastric and pancreatic cancer. So we're going to spend the rest of my time talking about what it means to have genetic predisposition to these cancers and how genetic testing could be helpful for some families. So 65% of the time, at least, gastric cancer and pancreatic cancer happen sporadically. That means by a combination of those risk factors that we talked about earlier, where we really can't pinpoint a single cause for a specific person. About 15 to 20% of the time, we can see gastric and pancreatic cancer that are considered to be familial. That means that we might see a clustering of these types of cancers in a family, but there's not a clear single genetic cause. Only about 5 to 10% of gastric and pancreatic cancer fall into that category, which we call inherited or hereditary gastric pancreatic cancer, meaning that there's a problem in a single gene that's being passed down through the family, causing higher risk for these cancers. So Jillian and Kelly are probably sick of hearing me talk about this, but these past couple weeks have been very exciting for me as my daughter, who is a freshman in high school, finally got to the genetic section of biology. So I have been reliving with her, learning all about genes and mutations and what that means. So I'm going to take you all down that path today to remind us what a gene is and how that can play into cancer risk. So you may remember, again, from high school biology, a gene is a piece of DNA that gives the body information on how to do a specific job, and genes are passed down to us from our parents. Most of the time, a person gets one gene copy from their mother and one gene copy from their father. In the body, we know that there are specific genes that control cell growth and division. So they essentially control the cells from growing into a cancer or stop the formation of a mass or a tumor. A mutation in a gene is a mistake in a gene that makes the body unable to do its job. So mutations in genes can also be passed down to us from our parents. So a healthy gene creates a healthy functioning protein, and a mutated gene creates no protein or a non-functioning protein. So if we're thinking in the context of a gene whose job it is to stop cancer from developing, if there's a mutation in one of those genes, it means that gene can't do that job properly, and the person who's inherited that gene mutation has a higher chance of developing cancer in their lifetime. It's not a guarantee that cancer will develop, but it gives that person a much higher risk than somebody who inherits a normal working copy of that gene. So we're going to talk more specifically about gene mutations that can increase the risk for gastric cancer as well as ones for pancreatic cancer. In the interest of time, I'm not going to waste anybody's precious minutes by reading this whole table to you. I just wanted to point out a couple things. First, the syndrome hereditary diffuse gastric cancer is the most significant gene change that we can see associated with increased gastric cancer risk. It can cause up to a 42% chance for somebody to develop gastric cancer in their lifetime. lifetime. And what's interesting about it is it specifically causes a type called diffuse gastric cancer, which is more rare and tends to be more aggressive. Interestingly enough, in these families, we can also see cancer in the breast lobules, which are the milk-producing glands in our breasts. So with this type, again, hereditary diffuse gastric cancer, we tend to see diffuse gastric cancer, lobular breast cancer. You can look at the rest of this table and see that there are other genetic syndromes that not only increase the risk for gastric cancer, mainly that intestinal type, but also increase the risk for other types of cancers. You can see some cause higher risk for colon cancers, for endometrial cancers, for thyroid cancer. So each gene has its own profile as far as risks that it causes. And we see the same thing with pancreatic cancer risk. There are several different genes that, when they have mutations, can cause a higher risk for pancreatic cancer. Again, all of these are for those adenocarcinomas, typically within the duct of the pancreas. You can see the biggest risk goes along with hereditary pancreatitis, but we can see gene mutations that cause a higher risk for pancreatic cancer along with melanoma, or along with breast, ovarian, prostate cancer, along with colon cancer, other female cancers. I know I sped through this. Jillian will give you information about how to access the recording for this webinar when we're done today. So please feel free to go back and look at those slides again if you want more information. So now that we've gone through that, you might be asking yourself, well, how do I know if I should be concerned about my family? What should I be looking for in my family history to indicate that there could be one of these genetic mutations? So there are, it's important to remember every family is going to look different. There's not really a template of what a family with hereditary cancer looks like, but there are certain key features that we tend to see in most of these families. First, any person with a diagnosis of pancreatic cancer, even without a family history, any diagnosis of a pancreatic cancer or a diffuse gastric cancer is rare enough that should indicate a genetics evaluation would be helpful. If we see 2 or more people in the same family with the same type or related type of cancer. So if we're seeing 2 people with gastric cancer, 2 people with pancreatic cancer, something to be concerned about. If we see a family member who's had more than one cancer in their lifetime, so maybe somebody who had a melanoma and then years later developed a pancreatic cancer. So that's a person who's had more than one cancer in their lifetime, even if they don't have a family history of other people with cancer, something to be concerned about and to look into. Also, if we see other types of cancers in the same family, where we see pancreatic cancer, gastric cancer, we already went through some of those other cancers on the chart, but in general, breast, ovarian, endometrial, other GI cancers can be concerning that there's an inherited condition in the family. Lastly, ethnicity can play a role too. Ashkenazi Jewish ancestry associated with pancreatic cancer does highly suggest that a person's family could have hereditary breast and ovarian cancer syndrome. So generally, people ask, what does Ashkenazi mean? That means people of Jewish ancestry from Central or Eastern Europe. If you're Jewish and you don't know if you're Ashkenazi, you can always ask me, or I can tell you as a rule of thumb, at least 90% of American Jewish individuals are Ashkenazi. So all things to look out for when you're assessing your own family tree. Okay. So how does genetic testing work? can we actually look at these genes to see if they have mutations? And again, absolutely, current technology makes it possible for us to proofread a person's genes to look for mutations that can increase cancer risk. What's really nice is these days, with just a blood or saliva sample, we're able to look at multiple genes at one time. So just with one sample, we can look at every single gene on those tables to tell a person if their genes look like they should, or if there's a mutation in one of those genes. Testing is most informative if it started with a family member who has been affected with cancer, but I never like people to think that that means that they shouldn't have a genetics evaluation if that's not possible in their family. There are plenty of families where it's just not possible to start the genetic testing with somebody's who has had cancer. If you have concerns about your family history, please reach out to the Impact program or let us help you have a genetics evaluation. So don't let that stop you from digging deeper into your family. Also, really important to remember when you start the process of genetic testing, this is a family affair. So you might be doing this testing to get more information about your personal cancer risks, but it's important to keep it into the context of if I find out that I have a mutation, this has information for my siblings, my children, because any of them would also have a 50% chance of having that same gene mutation. Okay. And Jillian, are you ready for this part of the, the talk?
Yes, I am. So we're going to be launching a poll, just asking a few questions about the family history that you see here, and it should automatically come up on your screen. All right, so you should see that in just a minute here. Go ahead, Julie.
So I like to call this how well did Julie teach us about inherited syndromes in the short time that she had. So what we're going to do is just play a little game where I'm going to show you a pedigree or a picture of a family tree and see if you all can guess if there's a syndrome in this family or if there's no concern about an inherited syndrome. I have to state these were made up. I completely made these up. These do not represent any families that we've seen in the impact program or that any of us have seen before in our career. I use the statement that they say at the end of movies, if there's any resemblance to reality, it is a complete coincidence. So just very quickly, squares are males, circles are females, lines between people show brother-sister or sibling relationships, and lines up and down show parent relationship. So in this family, we see a young man at 35 who was diagnosed with melanoma at 29. He has a 37-year-old sister who also herself had a couple bouts of melanoma. They never really thought about it though until their father was diagnosed with pancreatic cancer just recently. And on exam, the physician said to him, you know, you have some kind of weird looking moles. They look large, they look kind of atypical. And the father said that he's had those his whole life and that his kids have them too. Um, we can look one more generation up and see that the father's mother passed away of skin cancer, which the family feels was probably melanoma. That sister or that mother had a sister who died of a cancer in her abdomen. The family wasn't sure what that was. On the original patient, again, that 35-year-old mother side of the family, we can see his mother had breast cancer at 58, and he has a cousin who about 3 years ago had Hodgkin's disease. So can anybody guess what this family might have, or if they don't have anything at all?
We'll give everybody just a minute to respond here. And if you cannot see the pedigree, if you close the polls box on your screen, you can also find the poll in the meeting chat and can respond there as well. Okay, so Julie, it looks like many people have responded. I imagine you can see this in the chat as well, but it looks like 90% of people voted for familial atypical multiple mole melanoma, with a few people voting for Lynch syndrome and a few people voting for no concern for hereditary syndromes.
Yeah, this was a tricky one, but the people who said FAM got that right. So we can see in a family where we're seeing melanoma and pancreatic cancer together, that does raise concern for a condition called familial atypical multiple mole melanoma, which is very hard to say. So yeah, good job. I'm ready. Are you ready for me to move on?
Yep.
Jillian? Okay. All right. So in this next pedigree, we see a 42-year-old woman who was just recently diagnosed with breast cancer. On taking her family history, it was important for us to note that on her mother's side of the family, her mother's sister also just recently had breast cancer about 4 years ago. Then when we dug more onto the other side of the family, we see that the patient's father unfortunately passed away of pancreatic cancer at about 67. And, when asked about the father's family history, there's always been kind of the idea in the family that the patient's grandmother died of some female cancer, but nobody knew what it was. It wasn't clear if this was a cervical cancer or an ovarian cancer. They just knew it was a female cancer. We also know that the patient has a cousin related through her father's brother who had breast cancer also about 7 years ago. Of note, this family is Ashkenazi Jewish on the patient's father's side and French and English on the mother's side.
Okay, so just as a reminder, you can use the poll box that came up, or you can submit your response in the family number 2 section of the chat. All right, looks like we have multiple responses come in. And Julie, it looks like hereditary breast and ovarian cancer syndrome is 83% of votes, 9% for hereditary diffuse gastric cancer syndrome, and 7% for Lynch syndrome.
Great. Again, another tricky one, especially when we threw in the young female cancer. But in this family, what I wanted to point out is there was breast cancer and pancreatic cancer in the same family, where we see Ashkenazi Jewish ancestry, which is pretty much of a risk factor for hereditary breast and ovarian cancer, typically associated with BRCA2 in the situation where we see pancreatic cancer. I did want to throw in this family and the family before, it's very common, and you might see this when you're collecting your family tree, that in the older generations, there are going to be people where, it's been passed down through the family that she died of cancer, but nobody knew what kind. That happens, and sometimes you just have to use the context of the rest of the family tree to figure out maybe what it was that family member had. And this is our last family tree. This is a big family, but we have a 41-year-old woman who was diagnosed a couple years ago with lobular breast cancer. Her father unfortunately died young, about age 48, with gastric cancer. As we dug a little deeper, we saw that her father actually had a sister who had both lobular breast cancer and gastric cancer and passed away. That sister also had a daughter who had lobular breast cancer. There is a grandfather or grandparent on that side of the family who passed away in his 50s, but nobody knows why. And grandmother's still living at 93. On the patient's other side of the family, mom's alive and well at 70, except we know that mom's father had lung cancer and mom has a brother with prostate cancer. This or prostate cancer history. This family is African American on both sides.
Okay, so again, you can either use the poll box that's popped up or under family number 3 in the chat section. Okay, so it looks like many votes are in. About 61% of people voted for hereditary diffuse gastric cancer syndrome, and about 35% of people for hereditary breast and ovarian cancer syndrome, with one vote for no concern for hereditary syndromes.
Yeah, this was a tricky one too because I threw in three people who had breast cancer. But when you see that combination of breast cancer with gastric cancer, that is concerning for hereditary diffuse gastric cancer. Also, very quickly, I know we're running out of time, but I want to make the point that people might not always know if their family member had lobular breast cancer versus ductal breast cancer. Ductal is way more common. So even if you see breast cancer with gastric cancer and you don't necessarily see the word lobular with it, it definitely is worth considering this hereditary diffuse gastric cancer. I am going to turn it over to Kelly to talk a little bit more about the impact program. Kelly, do you just want me to advance slides for
Sure.
you?
Yep,
Okay.
that would be great, Julie. Thank you. Thank you. That does conclude our portion of the talk, focusing on the two cancers, gastric cancer and pancreatic cancer. And lastly, what I'm going to do briefly is just go over our program that we are a part of called the Impact Cancer Care Program. And following that, we'll have questions. So, Julie, you can move forward here. Julie, Jillian, and I are all navigators for the Impact program, and we are based in the United States. We did want to open up this webinar globally to be able to share it and for everyone who would like to have access to the information about the cancer risks and screenings that we discussed. The Impact program is based, like I said, out of the United States. We are available to those who are on a Thermo Fisher Scientific medical plan. That would include our colleagues, spouses, dependents, and partners. We are also available in the United Kingdom and in Canada. Our purpose is to provide support and guidance for anyone who either has a cancer diagnosis, is concerned about their cancer risks based on family history, or has any kinds of questions related to cancer. So if you're on this call and that applies to you and you're in one of those locations, please reach out to us and we can help. We also help to coordinate the different services that may be available to you, which could include some genetic counseling and potentially genetic testing based on your location, navigation of available benefits, and any resources that we identify that could be helpful. Okay, Julie, go ahead. I did already mention who qualifies. However, if you are not in one of the locations that I discussed, or you are not part of that subsection of people that would officially qualify, if you do have questions, you can always reach out to us, and we may be able to guide you to local resources that could be of assistance. So don't hesitate to contact us if you fall into that category. And lastly, if you or someone that you know or work with could benefit from our services, all you would need to do is email the Impact program at impact@thermofisher.com. It comes to the three of us. And what we would do at that point in time is provide you with an enrollment form, an electronic enrollment form, and then connect you with your navigator and send an email with the next steps on how to schedule a call with us. We have additional resources also available in the Colleague Service Center. If you are in, like I said, in the United States, the UK, or Canada, you'll be able to access some of that information from Colleague Service Center. You would just search Impact Program. And with that, like I said, I would like to open it up for questions. I would like to remind everyone that Julie, Jillian, and I are all certified genetic counselors here in the United States. We are not physicians, and so there may be some questions that we are not able to answer based on our level of expertise and our scope of practice. So if we're not able to answer your question, we may defer to a different resource that may be able to help. And so I'll let Jillian take over the questions that are in the chat because we have a lot of them, and anything we don't get to, you can always follow up with us by email and we can answer individually.
Okay, so we will get started. One of the first questions to come in was, Julie, is the risk of smoking different for smoking cigarettes versus cigars, or is it the same for both?
That is a great question. It's my understanding that any kind of smoke does increase the risk, but I do not know the differences between cigar versus cigarette. I don't know if Kelly and Jillian, you know.
I don't know if that's been studied, that there's definitely, I know that there's definitely an increased incidence for both, but I don't know the difference in magnitude.
Yeah, it's a good question though.
So there are a few questions here about family history. So if somebody has either a family history of cancer themselves or has multiple relatives that have a history of pancreatic cancer, um, should this be something that they should consider doing genetic testing for?
Absolutely. And as Kelly had mentioned, we are happy to help you out with that in the Impact program. If you enroll, we can talk to you more about your family history and help you through the process of genetic testing. Also, from the standpoint of screening and making sure that you're being followed by your physician appropriately, it's important to open up that conversation with your physician as well to talk about, what you should be doing to manage your risks.
Another question is, what is the difference in incidence of gastric cancers between males and females? And Julie, correct me if I'm wrong, but I think it's 2 to 3 times higher in males than in females, right?
Yes, I'm going to look up the specific numbers because that's a good question.
Mm-hmm. But I remember I remember from back in my student days it being somewhere around double to triple higher in men.
And, to keep in mind, just in general, even though it's higher in males, in general, gastric cancer in our country is a pretty rare. Yes, you're right. Men develop about 2 times more often than women. So let me see if I can find the absolute risks.
So there's a couple of questions, and Kelly, maybe you can touch on this about coverage for pancreatic cancer screenings for people that have either a family history or are interested in getting either the genetic testing and the cost thereof or in other types of cancer screening.
Yeah, absolutely. And again, I apologize. This is going to be a very US centric answer to that question. Here, a lot of times the genetic testing coverage by insurance companies is it follows along with national guidelines and insurance guidelines for what they will cover. Those are dependent on different criteria that you may fit based on age of a diagnosis, type of cancer, what the rest of the family history looks like. I can tell you that for things like diffuse gastric cancer and pancreatic cancer, those two diagnoses alone, even in the absence of a family history and regardless of age, would qualify for genetic testing and have it be covered. That doesn't mean that there's not going to be an out-of-pocket cost based on deductibles, co-insurance, co-pays, all of those things that we have here. Um, but that's sort of the general guideline is, discuss it with your physician or a genetic counselor, optimally a genetic counselor, so that they can walk through um, what would be available for you. Again, if you qualify for the impact program, we can do that for you. There's no cost to enroll in for any of those services, and we can certainly walk through your family history and discuss whether or not it would be needed for you or a family member to undergo that genetic testing.
And just to go back to the previous question, so in the United States, the risk for gastric cancer for a man is about 1%, and for a woman is 0.5%. So even though we say it's twice as common in men, just keep in mind that both men and women have a 99% chance at least of never developing gastric cancer.
Okay. A few other questions that had come up is, Julie, do you know the survival rate of pancreatic exocrine cancers? How often, this person asks, how often does pancreatic cancer develop from chronic and acute pancreatitis?
So those are great questions that Kelly was alluding to when she said that we don't have the medical expertise. So there are so many factors that go into determining the prognosis for specific types of cancers. So it would really depend on the size, when it was found, how advanced it is, treatment that was used, as well as when we're talking about pancreatitis developing into an exocrine cancer. Also depends on so many different things as far as the number of episodes a person's had, the age at which they happened, how they were managed. So those are great questions, but difficult to answer in a broad range, especially with from the context of people who are not physicians taking care of people with those cancers.
Yeah. Yeah, Julie, I was going to say to that, it's really hard to say, what, even with pancreatitis in specific, because it really depends on how acute the pancreatitis is, how long it lasts, and how much time is between different pancreatitis attacks. So
Right.
I feel like it's such a nuanced answer that is really, situationally dependent. We know that it certainly increases it, especially chronic pancreatitis. The numbers I had seen were 18 times more likely, but even then it has to deal with how long you've had it and how much inflammation they can see on the imaging.
Correct.
Um, all right. So another question that has come in is whether or not Medicare covers genetic testing and whether or not primary care physicians typically will order that testing.
Yeah, so I did provide an answer in the chat to the question about Medicare, which is in some circumstances, yes, they have their own guidelines for coverage. So certainly, speak with your doctor or one of us, about genetic testing and whether or not it would apply for you. So yes, it can be covered, but not always. It just depends on the guidelines and if you're eligible. As for primary care physicians, some primary care physicians feel more comfortable ordering genetic testing than others. It depends. Because we are genetic counselors, we still encourage if there is a genetic counselor available to you. We recommend actually seeing a genetic counselor over a primary care physician only because we have the expertise in the genetic testing and what kind to order. And then the follow-up also is something that we are trained in and have a lot of experience with. So yes, some can. Not all will, and some will refer you to a genetic counselor anyways. In terms of cost, again, if it's not covered or if you're looking to pay out of pocket at this point, usually it's a couple of $100s out of pocket. So I would say $200 to $300 is the estimate for an out-of-pocket cost for a genetic test. And I
Yeah,
think we have, yep, go ahead.
oh, the last question that's in here is how often should I do genetic testing? I will say that I tell my participants to go back to whoever did their genetic testing or see a genetics professional about every 5 years. And now I say, it's not that we anticipate that your inherited DNA has changed, but rather our ability to look at it has changed. But certainly, if there was a change in family history or a change in personal history before that 5 year mark, I think that's another consideration as well.
So I know we only have 1 more minute, or we're pretty much out of time. And so what I want to say is for any of the questions that we didn't answer, we will try to answer them in the chat. If we don't happen to answer your question, just based on our oversight, please feel free to send us an email again at impact@thermofisher.com. If you are interested in enrolling, you may also email us there. You do not have to give us any personal information, just your name and an email address for us to send that enrollment form. And then we can take it from there. So just give us some time, because typically after these webinars, we get a lot of emails. So give us a day or two, and we will begin responding and get everyone enrolled that would like to enroll. Any last comments by Julie or Jillian?
No, just a
No,
reminder that this was recorded today and it will be posted on the Impact Care CSC site. You can find the link at the top of the chat in our welcome paragraph.
and I was just going to say too, please don't feel embarrassed, or I feel like some of the questions are focused on, is this enough for me to consider having genetic counseling or testing? Please don't be concerned if you have any doubt or any concern about your family history. Nothing silly, nothing stupid. Just reach out to us and we'll help you.
Okay. Well, with that, we will go ahead and end today's presentation. Thank you to everyone that was able to attend. And please look for our next one that will come up later this year. Thank you. Bye-bye.